All right, welcome everybody. We want to welcome our patients, families, and the wider community today to talk about the newly improved infusion medication, Leqembi or lecanemab, for the treatments of Alzheimer's and answer all of your great questions today. I'm Kelly Bender. I'm the outreach liaison for UW Medicine Neuroscience and helping to with the administrative portions of today's webinar, as well as my colleague Genevieve Wanucha, who's here from the Brain and Memory Wellness Center as our communications specialist. So with me today, we've got a panel of experts, which include Dr. Grabowski, Dr. Rosenbloom, and Darla, our nurse practitioner. Here's a little bit more about each of them to get us started today. Darla is a clinical trials coordinator and clinician at the UW Alzheimer's Disease Research Center. She also serves as a nurse practitioner at the UW Memory and Brain Wellness Center. Darla received her board certification at the as an adult health nurse practitioner at the American Nurses Credentialing in 2016. Dr. Grabowski is a UW professor of radiology and joint professor of neurology. He's a neurologist and expert in the diagnosis and treatment of conditions affecting memory, language, and cognition. He's the director of our UW Memory, Brain, and Wellness Center. He's also a cognitive neurologist who directs UW Integrated Brain and Imaging Center, dedicated to investigating the organization of the brain and basis of cognition using MRI imaging approaches. And Dr. Rosenbloom is a board-certified neurologist at the UW Memory and Brain Wellness Center, where he directs clinical trials running through the UW Alzheimer's Research Center. He previously served as the director of the Health Partners Center for the Memory and Aging in St. Paul, Minnesota, where he did clinical research and cognitive screening for dementia, intranasal therapeutics, and non-invasive neurostimulation for neurodegenerative diseases. Here is our Memory and Brain Wellness Center team, who's important to this work. A few other housekeeping items for today. This webinar will be recorded, and we'll share the link out on our website, which Genevieve will happily help us post. Feel free to put your questions in the Q&A today, and we'll spend the majority of our time, the first part of our webinar today, going over some important information from our panel of experts, and then the remainder of our time using your answering those questions in the Q&A. So Dr. Grabowski is going to give us a great overview of this medication. Dr. Rosenbloom is going to talk about mechanisms or how it works. And then Darla is going to talk about safety and some of the monitoring and side effects with this medication. So without further ado, I will turn it over to Dr. Grabowski.
Great, thank you, Kelly. And good afternoon, everyone. I'm Dr. Tom Grabowski, and I'm the director of the Memory and Brain Wellness Center. And thank you for attending today. We're all here because we're interested in this new treatment option for early mild Alzheimer's disease called lecanemab or Leqembi. Kelly, could you advance to the next slide? And I'm pleased to present this information to you on behalf of the whole team. Many of you probably know some of the providers in our clinic, and Dr. Rosenbloom and Dr. Chapman will talk after me. So let's go to the next slide. We're going to talk about Leqembi. That's the brand name for lecanemab, which is the MAB part means this is a monoclonal antibody. Leqembi now has full FDA approval, and we also know that Medicare is going to cover this medicine for patients with mild early Alzheimer's disease. Our purpose in the webinar is to explain to you what treatment with lecanemab is about in order to give you, our patients and potential patients, accurate information and expectations about this medication and our plans to offer it. We are currently making the necessary preparations, and we expect it will be available in the Memory and Brain Wellness Center, certainly by the holidays. Next slide, please. So we're going to post this webinar video on our web page. The information we're giving you today is up to date, but we are expecting rapid changes in the sort of best practice with these medications in the months ahead. For example, there's another medicine called donanemab, which is related to lecanemab, which we expect will become available in the coming months. And all of this will keep up to date on our webpage. Let's go to the next slide and talk about what we think you need to know in order to understand Leqembi. And the first thing that I think is helpful to know is that there are two kinds of diagnosis that we will make in our memory and brain wellness clinic. The first is, what's the matter with memory and thinking? This is somewhere on a spectrum of, thinking and memory are objectively normal, or maybe they're objectively abnormal, and yet not enough to cause any impairment in daily living or any dependency on other people. And that pretty much defines this term in the middle of your screen called mild cognitive impairment. So that means there is measurable memory trouble and usually some cognitive trouble, but no compromise of independence. But if you have objective cognitive trouble and you are dependent in mild degree or more than mild degree on other people, that's what we mean by dementia. And if you could advance, Kelly, it's really this middle band, this mild cognitive impairment stage or very mild dementia, which is the target of the Leqembi medication. And that's because the medicine was evaluated for people with this about mild degree of severity in the clinical trials. Next slide. So the second kind of diagnosis we make is what's the matter with the brain? That is what we could see if we could look at the microscope. And that's where amyloid comes in. Amyloid is this protein that accumulates in the brain that we think is causative or at least part of the cause of Alzheimer's disease. And it's all the brown stuff you see in this slide at the right. And mostly what you see are clumps in all the corners of this image of brown stuff. Those are amyloid plaques in the brain substance. And then in the center of the screen, you'll see a narrow arrow and you see a little blood vessel, and in the walls of that blood vessel, there's also amyloid accumulated. And that turns out to be important, and we'll talk about that as we go. Leqembi is an amyloid clearing antibody. It is engineered to attach to amyloid protein, and then your immune system takes it from there to pull that amyloid out of the brain. And it will clear largely clear these clumps of amyloid. We can't really show you a before and after brain picture, but we can show you before and after brain scans that you see there on the left of showing, all those hot colors showing a high load of amyloid. And after treatment with this medicine, the picture might typically look like it looks at right there with a dramatic reduction in amyloid burden. Next slide. So that's kind of the basics. You're going to hear a lot more from my colleagues, but let me just leave you with a couple sort of pre-reinforce some take-home points for you. The first one is that the Leqembi is basically good news for the field. It interrupts some of the relentless biology of Alzheimer's disease. I've already talked about this big reduction in amyloid burden that happens. If you could advance to the next. And what's been really hard to come by is to show that it really also slows clinical decline. And you can see the separation of the curves there, the blue placebo line and the orange lecanemab line. And graphs are a little hard to understand sometimes, but one way to think about that is look at that red dot, which I put on the 12-month mark for the placebo group. And if you follow the dotted line to the right, it doesn't hit the lecanemab curve until 17 months. So that's 5 months difference in the clinical course that lecanemab leads to. So that's 5 months out of those 18 months. Gives you an idea of how much slowing we're talking about. And in conjunction with this biological effect, the reduction in amyloid burden, we think that's pretty exciting. We're making a difference in the course and the biology of the disease. Next slide. But having said that, you can see it's not a cure. There is still decline happening, just at a slower rate. And it's not appropriate for everyone, as I mentioned. It's really for people with mild early disease. And there are also patients who have mild early disease who won't be able to take Leqembi safely for other reasons. So we'll explain some of that. Taking Leqembi is a commitment. This is an intravenous medicine. We give by infusion every 2 weeks for about 18 months. So that means, repeated trips to an infusion center. And along the way, you'll need a handful of MRI scans to monitor for safety. And we'll talk a little bit about that next. So next slide. And the side effect that we're concerned to monitor is something you've never heard of. It's called ARIA. That's not even a real word. ARIA is an acronym that stands for amyloid-related imaging abnormalities. And I think the best way to understand this is that Leqembi, as an antibody, will attach not only to the amyloid in the brain substance, but also to that amyloid in the small blood vessel walls that I showed you a little while ago. And when we clear that out of the vessels, some of them may get leaky. You can get some fluid extravasation, some local brain swelling, even some micro hemorrhaging, some small scale bleeding. And this is what is detected with these surveillance MRI scans. So I'm showing you a couple pictures of MRIs there. On the left, you see the white area on one hemisphere of the brain. That's the brain edema or swelling that I mentioned. And on the right-hand image, there's a white arrow that points to about 4 very tiny little black dots. So that's the very small scale kind of blood product deposition in the brain that results from a little microhemorrhaging. This kind of thing usually happens when it happens. So maybe 1 person in 5 who takes the medicine. When it happens, it's usually asymptomatic. And the only way to find it is by doing these MRI scans. The good news is that with the surveillance that we do, serious adverse problems with ARIA are infrequent, and the great majority of people can finish a course of Leqembi safely. And you'll hear more about that. Next slide. And then the one kind of question that this seminar can't directly answer is whether Leqembi is right for you personally. It's really a case-by-case decision. There's many factors to consider. I've mentioned some of them already. There's some medical factors like your cognitive stage, your brain scans, your amyloid biomarker, even genetics, as you'll hear, and your individual health and the medications that you take. So we factor all that in. There also are important personal factors that you help us decide about, how you weigh the potential benefit that we expect from this medicine against the risk and the cost of it, and the inconvenience, I guess you could say. How well Medicare and other insurance is going to cover this for you, and how easy or hard it is for you to get into the infusion center as often as you will need to. And all of this will determine together over 2 or 3 visits to the Memory and Brain Wellness Center. And this is a discussion and decision for you and your memory and brain provider to make together. And then my last slide. Just want to leave you with the idea that we are excited about this medicine. It's the first disease-modifying treatment for Alzheimer's disease that we have, and we have the opportunity to bring it into reality for our patients in a safe way. More generally, the availability of Leqembi is going to really increase the value of early diagnosis. I hope that we will see people diagnosed sooner when we can make a bigger difference, and drive the availability of new diagnostic tests. We expect more developments in the future. We hope this is just the first foothold on Alzheimer's disease, and that there are larger groups of patients in our clinic that will benefit from this treatment as time goes by. So with that, I'm going to conclude my part. I'm anxious to answer your questions, but first I'm going to turn over the podium to Mike Rosenbloom. Thank you.
Thanks, Dr. Grabowski. So I'm Dr. Michael Rosenbloom, and I'll be talking about the mechanisms of lecanemab or Leqembi action and giving you dosing information. Next slide. So if you were to look at the brain of a patient with Alzheimer's disease under a microscope, you would see two different things. And Dr. Grabowski has hit upon this topic. So number one, you would see these circular entities that you see in the upper right-hand corner and in these brown circles in the lower left-hand panel as well. These are clusters of a protein known as beta amyloid, and it's in the form of a plaque. So we call these amyloid plaques. And the other entity you will see are these kind of intracellular inclusions we call as neurofibrillary tangles. And these are designated by an N sign in both of these slides. So essentially, to have Alzheimer's disease, you have to have the amyloid plaques and these neurofibrillary tangles that are found. And we know that these findings are common in patients with Alzheimer's disease. The question is, if you were to give a drug that will remove at least one of them, in this case, the amyloid plaque, will it affect the clinical presentation of the patient? And that's what a drug like Leqembi will help us to answer this question. Next slide. So Leqembi is a drug that is a monoclonal antibody that is designed to act and bind specifically to the A-beta protein that forms these plaques. And the drug will bind specifically, and then an immune reaction will take place. And essentially, there's clearance of this abnormal protein and clearance of the amyloid plaques in the brain of patients with Alzheimer's disease. Next slide. So this cartoon shows exactly what is happening in the brain of a patient who is receiving the drug. So you see the patient who has an IV infusion bag. This includes the lecanemab or Leqembi. The drug will go to the brain and then cross the blood-brain barrier where the drug will bind specifically to the amyloid plaques that are present within the brain. The antibody will then take the amyloid out, and then once the antibody is bound to the amyloid, there'll be an immune reaction, and then this leads to clearance of the amyloid. And so what we have here is a treatment that removes amyloid, and we're hoping that there'll be some type of ramification in terms of cognitive and functional decline. Next slide. So I should first say that the patient population that we are targeting is early stage Alzheimer's disease. At this point in time, we understand Alzheimer's disease as a condition that's on a continuum. And the National Institute of Aging and the Alzheimer's Association has a 6-stage staging system where we acknowledge the fact that in the early stages, known as 1 to 2, that patients have preclinical Alzheimer's disease. This is a condition where patients have the amyloid plaques and the tangles in the brain, but they're free of any symptoms. And then you have stage 3 and 4 that refers to mild cognitive impairment, as well as mild Alzheimer's dementia. And the fine line between what we call mild cognitive impairment and mild Alzheimer's dementia is the ability to do what we call the instrumental activities of daily living, such as cooking, grocery shopping, and driving. If you can still do those things in the setting of cognitive impairment, then we call the condition mild cognitive impairment. But if you are no longer able to do these activities, then we would say mild Alzheimer's dementia. As the disease progresses, patients develop moderate and then eventually severe Alzheimer's dementia in the latter stages. Now, the philosophy towards the use of this drug is for early stage Alzheimer's disease. And the concept is very similar to how we treat cancer. So typically we treat tumors when they're localized before they've metastasized. And similarly, we are treating Alzheimer's disease when it's quite localized in the brain and hasn't caused extensive cerebral and brain damage. Next slide, please. So we do have the ability to use a special type of scan that Dr. Grabowski alluded to in his presentation. We call this an amyloid PET scan. And it's a scan that allows us to see the amyloid plaques in a living individual. The way it works is a patient will receive an injection of an IV contrast that binds specifically to the amyloid plaques in the brains of patients. And when you image the brain, you can see these red, orangish areas in the front and the back of the brain. And this all correlates to the deposition of amyloid throughout the cortex. Now, when you give a drug like Leqembi, it is an agent, as I said before, that will remove the amyloid plaques. And we know that in a good number of patients who were involved in the clinical trial, that their brains look like what you see on the left side here, that these plaques that were present in an Alzheimer's patient are no longer present. And essentially, if you image the brain in these individuals, it looks like a normal individual. The big question is whether or not there are cognitive and functional benefits. And we know that in prior trials, there have been drugs that have been studied that are very good at removing amyloid from the brain, but have no effect on slowing cognitive and functional decline. Next slide, please. So I will direct your attention to this figure that you've seen in Dr. Grabowski's slides. And I know that this can be sometimes hard to interpret, but let me kind of direct your attention to the lower part of this figure where we're seeing the visit time in months. So essentially the study that has led to us discussing Leqembi is, it was an 18-month trial looking at the effects of this drug in patients with early stage Alzheimer's disease. And then half of the patients received the drug, and then the other half received a placebo. And the way that we measure how effective the drug is by doing a measure that combines cognition and function. And that is what you see on this axis here. And so for an effective drug, what you would want to see is some softening of this curve, of this slope, and slowing of this cognitive and functional decline. And as you saw from Dr. Grabowski's slides, that when you compare the actual population of patients receiving drug to those receiving placebo, there is a relative slowing by about 27% of decline in cognition and function at 18 months. So this is a significant result. And as a potential patient, you may ask the question, well, what does this mean for me? And statistically, this is a 4 to 5 month delay in disease progression over an 18-month period. That's all we know from this clinical trial. It does not restore lost function. So for instance, if a patient developed early stage Alzheimer's disease and they could no longer drive, it's not like taking this drug will restore the ability to drive. And this is not a cure. It's not curative at all. And also it is quite a commitment and involves infusions of the drug at an infusion center every 2 weeks for at least 18 months. What happens 18 months, we are not sure. We only have data for patients who've received Leqembi for an 18-month period. Next slide. So I've talked about the effectiveness. I also want to say a couple words about the side effects and adverse events. You'll hear more about this from Darla Chapman. So about a quarter of patients receiving the infusion of Leqembi experienced an allergic-like response. We refer to these responses as infusion reactions. And often these are present immediately after you give the infusion. This is something that infusion nurses deal with many other types of drugs, but at least for Leqembi, it was close to and a little bit over a quarter of patients receiving the infusion. The other significant side effect I'd like to point out are the effects on the central nervous system. And there is this phenomenon known as ARIA-E that refers to brain swelling. And when you do an MRI, you can see this swelling as depicted as this area of whitening. And this is something that we will be screening for throughout the course of treatment. The other possible central nervous system manifestation involves brain microhemorrhages, and we call that ARIA-H, and that is found as these little black spots on a special sequence of the MRI that detects blood. We know that certain individuals who have a genetic risk factor for Alzheimer's disease are at greater risk for these central nervous side effects. So this risk factor is known as ApoE4, you can have up to 2 copies of this ApoE4 genotype. You can also be ApoE2 and 3. If you're ApoE2 or 3, that has no effect on this risk for ARIA. But if you are a carrier of ApoE4, you will have an increase in your risk for having these side effects. And so somebody who is a carrier of, let's say, 2 copies of ApoE4 may be a little bit more reluctant to undergo this treatment. The thing that also should be known is if you're going to experience the side effects of ARIA, they will most typically occur within the first 4 months of treatment. So if you are being treated beyond the first 4 months, you're likely out of the woods. Next slide. So from what I've told you, half of you in the audience might be thinking, well, this sounds great. We have a drug that is disease modifying, that removes amyloid plaques from the brain. And the other half of you might be saying, wait a minute, this only slows the disease by 4 to 5 months and it causes brain swelling. This is probably not worth it. And so, as clinicians, we have to figure out a way to optimize the risk-benefit ratio. We have to choose the right patient who is most likely to respond and has the lowest risk of side effects. Next slide, please. So there is what is called the appropriate use criteria, where we have a protocol where we choose those patients who are most likely to benefit and exclude those who are more likely to have the side effects. So I'm not going to go over this inclusion-exclusion criteria in full detail, but I will highlight some of the more salient points. So first of all, we want to make sure we have patients with early stage Alzheimer's disease. There's no evidence that Leqembi is effective in moderate or severe stage Alzheimer's disease. And one way in clinic that we determine this is by doing a cognitive screening test known as the mini mental status or the Montreux cognitive assessment. And patients who lie within a certain range of scores will be eligible. The other thing I should say is that we want to make sure that there's some evidence for Alzheimer's in the brain. So certain centers may have the ability to do one of those special amyloid PET scans. In our clinic, what we do is we do a spinal tap where we look at the spinal fluid and we can see proteins that correlate with the plaques and tangles in the brains of patients. And if you have a profile that is consistent with what you would expect in Alzheimer's disease, then we would have the patients proceed with receiving Leqembi infusions. Now, on the other part of this slide, we are also using criteria to make sure we do not include patients who are more likely to have either the brain microhemorrhage or the swelling. And so all patients at the Memory and Brain Wellness Center will have a baseline MRI that will look for any prior evidence for microhemorrhages or extensive strokes in the brain that will make patients at greater risk for having these complications. The other thing that we will make sure is to avoid giving Leqembi to patients who are on blood thinners like warfarin and apixaban, because we know that the combination will increase the risk for brain hemorrhage. Next slide, please. So I just want to highlight what we do at the Memory and Brain Wellness Center in all patients prior to receiving Leqembi. Patients will undergo a lumbar puncture or a spinal tap. A lot of people in the community hear those words and they get very nervous. I want to assure you that this is a very routine test that we do that has minimal complications beyond low pressure headache. It's also done by an expert in our general neurology clinic. And patients essentially will lay down on their side and a needle will be inserted. The spinal fluid will be collected and then sent out. And then we will get a result that looks at proteins that correspond to the plaques and tangles. And based on the ratio of these proteins, we can rule in or rule out Alzheimer's disease. I tell a lot of patients that it's like a pregnancy test. You're either positive or negative. The other labs that we are interested in is making sure that patients do not have a bleeding diathesis. So we will check labs to rule that out and make sure that they're not on any types of blood thinners. And also that genetic risk factor that I referred to in my prior slide, the ApoE genotype, we will also be making sure that patients are not carriers of ApoE4. And if they are, we will have a informed discussion about risks and benefits of proceeding. Next slide. So here is a patient pathway or a map of what to expect if you were to present to the Memory and Brain Wellness Center. So if we begin at start, we may see a patient who's referred either internally within the University of Washington system or externally. And at their first visit, we will do what we typically do and have been doing for many years. And that includes taking a detailed history, doing cognitive screening, doing laboratory studies, and sending patients for brain imaging if these images have not already been obtained. There will be an extra step that I've highlighted in red where we will be obtaining these biomarkers. And in our case, it will be sending patients for the spinal tap and the lumbar puncture to determine whether or not that there are proteins that correspond to Alzheimer's disease. That's at visit 1. And then eventually at visit 2, we will have a family meeting where we'll discuss the diagnosis and prognosis. And in addition to that, we will have that conversation about whether or not to proceed with Leqembi. If there is interest in proceeding with the treatment, we'll have a discussion about whether or not our pharmacy feels that the patient meets criteria for the use of Leqembi. And then there will be a portion of patients who may need financial assistance. So I should tell you that this drug costs $26,500 a year. And Medicare will pay for 80%, but the 20% is essentially coming out of the patient's pocket. And that will be challenging for some families. And so we do have a pathway for patients who may need financial assistance, and we have that well established. So once we have that meeting and the patient decides they want to indeed receive Leqembi, we will order the genetic testing and also the tests to look at bleeding. And then there'll be a third additional visit where we'll discuss the genetic testing, the laboratory studies, and then we'll talk about risk versus benefit. And there may be some patients who feel that the risk is too much, in which case they will carry on with the usual treatment. And then there'll be that set of patients who do want to proceed. And this is when we start with the infusions every 2 weeks. And as I said, this is treatment for 18 months. There is good data that shows us what happens at 18 months, but we do not have data that shows what happens after 18 months. And hopefully we'll have that information in the near future. Next slide. So what to expect with Leqembi infusion? So I should say that all of these infusions will be done at the Harborview Medical Center, and the infusion nurse will ask screening questions to make sure that you're not having any side effects such as headache or dizziness or problems walking, which are common in patients who are having the ARIA side effects. An infusion will last approximately an hour, and at least at the beginning, we will want to observe any patient for 3 hours. And we're doing that to make sure that there's none of the hypersensitivity reaction that I mentioned in about a quarter of patients receiving the drug. The observation period will eventually be about 30 minutes afterwards, after we made sure that the patient is unlikely to have an infusion reaction. Next slide. And this figure shows you kind of the number of infusions and then when we are going to get further imaging. So I mentioned before that we want an MRI at baseline, and then we have MRIs prior to the 5th, 7th, and 14th infusion, and then one at 52 weeks. Why are we doing these infusions? It's to capture the ARIA side effects that are found in the brain, that cerebral edema and the microhemorrhages. The majority of patients are asymptomatic, and so we need these screening MRIs to detect these changes. The other thing that we will be doing is having more frequent clinic visits, ranging from 3 to 6 months, to make sure that patients are doing okay. If patients have any symptoms or if they have any changes on the MRI, then we will schedule them urgently to make sure that we take appropriate action. Next slide, please. So I will turn things over to my colleague, Darla Chapman, who will talk about safety and side effects related to Leqembi.
Thank you, Dr. Rosenbloom. And I just want to echo a couple of things that have been said already. First by Dr. Grabowski, that it's really exciting to see so many people in attendance today. It tells me that a lot of people are excited, a lot of people are curious, and we just want to let you know that we are working very hard behind the scenes at the Memory and Brain Wellness Clinic to be able to provide this medication to people who might benefit from it. But we also want to make sure that we have processes in place to offer it safely, to be able to monitor for potential side effects and address them if they occur. Our priority will always be for the health and safety of our patients. And I'm going to go into some specifics about side effects, although much of this has already been covered, but I think I'll just provide another good overview of it so you know kind of what we're looking for and what you might look for. So next slide, please, Kelly. So as mentioned, this is a drug that's given through a vein, through an intravenous infusion every 2 weeks for about 18 months. It's given in our infusion center here at Harborview by nurses who are skilled and will be knowledgeable about the medication, how it works, and the possible side effects. Dr. Rosenbloom talked briefly about possible allergic reactions. We sometimes call this hypersensitivity reactions. You know, everyone's their own chemical pot. We don't know how people will typically respond to new medications. But in the study of lecanemab that we are basing our appropriate use criteria on, the most common allergic type reactions were what's listed here on this slide. And these occurred in about 21 to 26% of individuals who received the drug. So fever, flu-like symptoms, nausea, vomiting, dizziness, changes in heart rate, difficulty breathing. And then we also want to watch for more serious allergic type reactions where you would have like swelling in your face or your tongue. Our infusion nurses are very skilled at watching for these possible reactions and have everything they need at our infusion center to respond to them. And you will be asked a series of questions every time you come in about whether or not you experienced any of these kinds of things. Next slide, please. And then we have talked a lot about ARIA, amyloid-related imaging abnormalities. Again, this occurred in about 21% of people in the original study. It's most commonly noticed on brain MRI as temporary swelling or bleeding in areas of the brain that usually resolve over time. Does not typically cause symptoms. We usually see it on imaging. Only about less than 3% of people who had these changes on imaging actually had symptoms, and I'm going to talk about those symptoms in a minute. Like Dr. Rosenbloom said, these ARIA changes that we see on imaging are most likely to occur in the first few months of therapy and have increased risk of occurrence in people with a specific genotype. Next slide, please. So these are the kinds of symptoms that we would want people to watch for in terms of ARIA. You could think about these as neurologic symptoms, so headache, confusion, dizziness, vision changes, nausea, difficulty walking, seizures. These are all concerning symptoms that should be reported to us immediately. These are the questions you will also be asked every time you go in for an infusion before you receive an infusion. And if you have any of these symptoms, the infusion nurses will notify us to make sure that it's okay or not okay to give you an additional dose. We want to make sure that you do notify us immediately if you are receiving this drug, if you have any of these symptoms, or go to the nearest emergency room. Full disclosure, we do know that 3 people who were receiving this drug in the original study passed away. Those individuals had other risk factors for ARIA or may have been taking blood thinners that increase their risk for ARIA. Next slide, please. So there are a series of visits, as Dr. Rosenbloom kind of put out for us on his diagram, that will be required of our individuals taking this medication so that we can make sure that it's safe for you to take the medication. And during that review, we will go over all of your health conditions, any medications that you take. Particularly, we're looking for people who are taking anticoagulants who may not be a good fit for this drug because of the risk of little brain bleeding. You'll have brain imaging prior to starting this drug, and some blood drawn to check your blood clotting and this ApoE genotype that we've talked about. Additionally, we're going to be asking all of our patients to carry a medical alert card. We'll provide that to you so that if you present to another healthcare institution or you have a medical emergency, you can present this to the healthcare providers so that they know you're taking this medication and can make sure that they're not giving you other medications that can increase your risk of ARIA. Next slide. A little bit more about monitoring. Like the previous slide mentioned, we will do brain MRI prior to the first infusion, and then before infusions 5, 7, 14, and 52. That's because if ARIA is going to happen, it is most typically seen in the first few months. So we want to capture that if it's happening. And we may ask you to have additional brain imaging if you develop ARIA or new symptoms that are concerning. And we will always ask you about possible side effects, new medications, or medical conditions prior to each infusion. Next slide. I like this little handshake slide because what it's really saying is this is a partnership between your healthcare providers at the clinic and you. We need to work closely together to make sure that we're communicating any changes in your health, any new medications that you may be taking. So if you're prescribed this drug and you go to another provider, healthcare provider or primary care provider, and they want you to take a new medication, that you communicate that clearly with us before we give you additional doses of lecanemab. We want to make sure there's no contraindication or additional risk to you. And we always will ask you to carry a medical alert card in the event of a medical emergency. Next slide. This is just how to contact us. We are going to open it up for questions in a second, but all of this contact information should be on our website. And all new information regarding the availability of this drug and how we can get it rolling for you if you're a good fit will also be posted there. Next slide, please. So I'm going to turn it back to Kelly, who's going to I think you're going to coordinate our question and answer session.
Yeah, thank you. Thank you all. So it looks like there's a lot of great questions here in the chat today. And so I'll read them aloud and pick a panel or panel member to help answer the question. So Dr. Grabowski, the first question, are there age restrictions for this medication? Oh, you're on mute, my friend.
No, there's not a primary age restriction. It's more a restriction on general health, what other medical conditions might be going on and so forth. Yeah.
Sounds great. Dr. Rosenbloom, are there blood thinner restrictions?
Yes, so as I mentioned in my slide, that any patient who's on a blood thinner like warfarin or any of the drugs that we call our direct oral anticoagulants, those are essentially contraindications for moving forward with Leqembi. Now, patients can be on aspirin and patients can be on Plavix individually. There is some controversy of what to do when they're on both. There are certain centers that are not allowing patients to be on both and receive Leqembi. But if there's any type of anticoagulant, then that would be a contraindication for Leqembi use.
Fantastic. Here's another great question for you, Darla. Why is Leqembi only approved for mild symptoms? Do you expect it to be approved for moderate or severe cases eventually?
That's a hot question. I think the idea behind these drugs is that we want to get to the pathology of Alzheimer's disease, which is the amyloid accumulation, prior to any neurodegeneration that can occur. So the earlier we can get to that process, the better. I don't know what future trials are looking like, but right now these drugs are really being studied more in the earlier processes of the disease.
Maybe I could amplify on that just a little bit. I think there's a couple factors there. One is with prior experience with anti-amyloid agents, the suspicion has been that we need to intervene as early as possible. So that's one thing that made this trial be done in people with very early disease. And the other concern is that as disease is more advanced, that the risk of the ARIA is probably going to go up. So I think the primary thing keeping us from offering this to people with more advanced disease is twofold. One is we're a little more skeptical about the efficacy, but we're primarily worried about the safety. Yeah.
Sounds great. Dr. Rosenbloom, if a person requires around-the-clock care, is Leqembi right for that person?
So, yeah, I think if somebody is dependent for, let's say, ADLs, bathing, dressing, toileting, likely they would not be a great candidate for this drug. So, the study that was done, it's called the Clarity AD trial. It was looking at early stage Alzheimer's disease. And so there's no evidence in this population. And also to echo what Dr. Grabowski said, if you're going to use an anti-amyloid drug, it makes sense to do this in the earlier stages, and the efficacy will probably be less later on. The other thing to keep in mind is this drug is not completely benign. It can have significant central nervous system effects. And so that risk-benefit ratio that I alluded to in my slides is unfavorable for someone who is in the later stages of dementia and requires 24/7 care.
Thank you. Dr. Grabowski, can infusions be done at a local center, or do they always have to be done at UW?
So that I saw that question coming. That's a great question. Right now, they have to be done in our center. We are concerned. Everybody's on their learning curve with this medication. You've heard a little bit about, it's a trade-off between efficacy and risk. And we really are keen to minimize risk. So we want to be here with, the same kind of brain scan each time to monitor for the ARIA, to be as sensitive to it as possible, and to have as much control over the process as possible. Having said that, I think the future is, yes, I think this is going to ease up. I know there are even people out there, starting businesses for home infusion and so forth. So I think, in the future, probably in the later stages of the treatment course, when the ARIA risk has declined, I think maybe some of this will be done less centrally, but for now it has to be done here.
Thank you.
Yeah.
Darla, here's a question for you. Is there any potential for this medication being applied to Lewy body dementia?
Yeah, no, I don't. It would not be appropriate for Lewy body dementia, because Lewy body dementia is a different pathology. It is not a pathology that has to do with amyloid necessarily. And some people can have more than one pathology in their brain that causes their cognitive decline. But this drug is really targeting the pathology of Alzheimer's disease, which is the amyloid protein. There is a different protein involved in dementia with Lewy bodies.
Thanks. Dr. Grabowski, here's a question for you. You've got a patient with some heart issues. Would that be a potential candidate?
So in general, that's a depends question. Some people with heart issues, for example, have pacemakers, and people with pacemakers generally can't have MRI scans. So that would mean we couldn't keep track of ARIA risk for a patient like that. So for people that have contraindications to MRI, like a pacemaker or a defibrillator that's implanted, or severe claustrophobia, or any reason that they can't have MRI, they would be excluded. And we would also take a look at what other, what other things were going along with that heart disease. A lot of people are on blood thinners. A lot of people have had small strokes. So I think it depends question. Yeah.
Sounds great. Dr. Rosenbloom shared the amyloid clearing meds not translating into clinical changes. What explains the different result with Leqembi? Does it clear the amyloid in a different way?
Oh, that's a great question. So, a lot of us in the behavioral neurology and cognitive neurology realm are debating why there were certain drugs in the past that were of the similar mechanism to the Leqembi, but they didn't reach the same level of efficacy. And I think it all boils down to probably two factors. Number one, those prior studies did not have the rigor that the Clarity AD trial did, in that they required that patients had biomarker evidence either on a PET scan or from the spinal fluid to confirm that they truly had Alzheimer's in the brain. And so, the lack of that rigor in the earlier trials may have been a factor. The other thing I would say is that, we learned over time that giving the drug at a higher dose for a longer duration leads to greater and better outcomes. And so, in the past, these drugs would be given at lower doses less frequently. And here we have a drug at a relatively high dose given every 2 weeks. And so that likely, as you get it to a high enough level in the brain, then you're probably going to get a better outcome. And that's the best explanation I have.
Thank you. Dr. Grabowski, does the presence of one copy of the E4 exclude you from qualifying for the use of this drug?
No, it doesn't. It doesn't exclude you. So we get more nervous about 2 copies. So this ApoE is a strong, ApoE4 is a strong risk factor for Alzheimer's disease. And in fact, more than half of patients with Alzheimer's have at least 1 copy. Okay, it's that, and it's safe to say that the majority of the people that were in this clinical trial had 1 copy. So the results that we're talking about here, the mainstream results for this study, apply to people with 1 copy of E4. But 2 copies of E4, that's another story. There's a little higher risk. So if you're in that like 1% of people that have 2 copies of E4, then we will have more conversation with you about risk.
Thank you. Darla, does the emerging data on donanemab compare to the evidence base for lecanemab? If a patient begins treatment course for lecanemab, will they be barred from switching to the donanemab?
That is a really good question, and I'll let Dr. Rosenbloom or Dr. Grabowski chime in here, but I don't think that we have enough data to know like head to head how these agents compare to each other, or if it is safe to switch from one to another. Have you, Drs. Rosenbloom or Grabowski, heard any new information about that?
Yeah, I have no, not great information about what happens when you switch from one to the other. The risk for ARIA in the donanemab trial is a tad bit higher than for lecanemab. So that's one thing to keep in mind, is that there may be a greater risk for the ARIA side effects. The other thing about the trial that was quite unique is that they took an induction treatment approach that really is similar to induction therapy that you use in chemotherapy for cancer. So what was done is that patients received the donanemab for a period of time, at least a year, and then they looked at the amyloid PET scan at baseline and then afterwards. And if there was a significant amount of clearance from the amyloid PET scan such that it looked like a normal scan, then the patients went off the donanemab. And it was found that you still get positive outcomes. And so perhaps you get to the point where you remove enough amyloid, you can get benefit and you don't have to be on the drug continuously. So it's an interesting idea because, thinking about the 6.7 million individuals who have Alzheimer's disease and those who will require this type of treatment, are we going to give infusions every 2 weeks for the rest of their lives? Or do you take an induction therapy approach where you give it for a period of time and you make sure that the biomarkers are addressed? So that was something that was really unique about the donanemab trial.
Yeah, and I'm going to add a comment. So I think to a first approximation, the degree of benefit for donanemab and lecanemab is very similar. It's not very different if it's different, and the side effect profiles are similar. although maybe there's a small difference in favor of lecanemab. It's hard to say. This is a good example of an area where I think there's going to be a rapid change in best practice over time. We are going to learn better how to define when to stop giving these medicines. The people that were in the lecanemab trial, yes, they got the trial to 18 months, but they're still being followed. There's still data that are going to come in about what their subsequent course was like. So we're going to learn more over time about how to sort of titrate the endpoint for the treatment. But the basic question is nobody knows whether you can mix lecanemab and donanemab. Yeah.
Sounds great. Darla, can you travel in between doses, and can your dose be delayed?
Oh, yeah, absolutely. We are not expecting people to, sit around at home waiting for their next infusions. We want people to, live joyful, meaning lives. I believe that the timing is every 2 weeks, give or take. In the studies, sometimes doses have to be missed, and we just kind of play catch up. So it's not. We like people to stay on a regular schedule, but we realize people have to move about on the earth and visit family and take vacations and things too.
Sounds great. Dr. Grabowski, there's a lot of questions in here about coverage. There's questions about are MRIs covered and the infusion costs covered?
Right. So that's a great question. So the basic thing is Medicare will cover, so that for most people taking lecanemab, they're going to be Medicare eligibility age. We do have a few people who in our clinic who are younger, and that's a different story. We do not yet know, by and large, what the secondary insurers are going to do with this. So I think that's an open question. If you are, determined to be a good candidate and you want to move forward, there will be a conversation with your carriers that UW Pharmacy will do before they will, put you in line to get an infusion that's expensive. And there's also a process to go through with the drug manufacturer, because they also have case managers available to help you make sure that you get the best coverage that you can get for this, and even some assistance in some cases. So that there's a process for that. We wouldn't launch lecanemab without a serious assessment of that for you. With respect to the MRI scans, those would also be pre-authorized with your insurance. And what we're trying to do is to pre-authorize all of the surveillance MRI scans in a bundle. I don't know if we're going to be able to do that. That is a thing we're actively working on. But the FDA label for lecanemab says you should have scans at these particular points in the treatment course. So we think that we will probably prevail on that. So those are the expensive pieces of the treatment. Right now, 80% is covered. The 20% is where the conversation is.
Thank you.
Yeah.
Dr. Rosenbloom, if a patient's had a lumbar puncture prior, will it be repeated?
Yeah, so I think, if a patient has had a lumbar puncture that was specifically looking for Alzheimer's biomarkers and was positive, there's no reason to repeat the study. Essentially, if it's well established that there is biological evidence for Alzheimer's disease, then that is something that will be taken into account when they are being evaluated for Leqembi.
I'll just add that I think the hope for the future is that we at some point will have a plasma or a blood biomarker that would substitute for a lumbar puncture. We're not there yet. You may be hearing about things about blood biomarkers for Alzheimer's disease, but we're not clinically using them yet. We don't quite have enough information. And I think that will be another evolving piece to this, to being able to offer this drug.
That's a great point. And it's not as far off as you might think. We use them in research all the time now, and it's coming in the next few years for sure.
Sounds great.
Yeah.
Well, I really appreciate we're concluding our hour today, and I appreciate all of you joining us today. I hope we answered lots of your questions. I'll be sending out a follow-up survey to you all to see what you enjoyed most. If there's topics you'd like us to come back and cover, please do fill out the survey. We've also got some other community events with the Memory and Brain Wellness Center that we may be sharing. So please let us know if you're interested in hearing more about that. Again, this recording will be posted on our webpage, and appreciate you all joining us today.
Thank you, everybody.
Thanks.